Thank you, Gilles, for your nice announcement. And thank you all very much for staying so late to listen to us. Um, I won't take too much of your time. I just want to share some of my experiences and my thoughts on the problem. The majority of the things you have heard already throughout the day, so I'll try to be quick. Uh, so, groin pain, as we know since 50 years ago, was defined as pain in the inguinal and or adductor region related to sports activity, and the reason for that was the abdominal wall and adductor muscles imbalance. So, in 1967, an orthopedic surgeon, at that time 37 years old, from Belgrade, Serbia, did the first inguinal repair for a football player with long-standing groin pain. He'd never published it, and so to the majority of the world, it was not known. He was Dr. Nesovic was a football player himself, and even an orthopedic surgeon. He got this idea to try to help the player by, instead of doing adductor tenotomy, what was done in Spain at that time, he tried to enrich the poor instead of cutting the rich, and to reinforce the inguinal region, because we know at that time that football players had very strong legs, and the abdominal wall was not so strong. The patient was Joric. He was a left back, and he's still working in the Football Federation of Serbia now. Then we have some people who had the same idea later and became big names, like Dr. Gilmore in England, and he started in 1980, and it was named in England, the problem is named Gilmore groin, and by personal communication I found out that he never heard of Dr. Nesovic before, and it was nice that he was really surprised that it was so much before him. But what I want to point out here is that Dr. Gilmore, according to their website of Gilmore Groin and Hernia Clinic in London, over 30 years, saw 7,700 patients and performed 4,300 surgeries, which is like 61% of the patients seen. And apparently 96% success, but no evident follow-up. So I would like to point out that it's important to be aware of oversimplification, and things might look a little bit different when you have a closer look, like this painting of famous painting of Lincoln by Dali in his museum. When you come closer, you can see it's Gala Dali looking at the Mediterranean. And why I show this, there was a study done by some guys in Manchester, a questionnaire with cooperation with European Hernia Society, and investigating how many hernia surgeons are treating groin pain, and they found out that 97% of people who are treating groin pain see less than 10% per year. So it's not such a big number. So we come to, over time, we develop the concept of core stability, which is very important, and even for a general surgeon. And we need to take this into consideration. It has had different names over time, but we like to stick to stability. And by definition, dynamic stabilization refers to the ability to utilize strength and endurance in a functional manner through all planes of motion, despite changes in the center of gravity. Dr. Childers will love this photo because it's from 1982, not 86. So the core has been defined as a box, and we have been talking about the abdominal muscles and a little bit about some of the muscles from the posterior abdominal wall. But we have to know, of course, there are global dynamic and local postural muscles, and the local muscles, which are attached to the spine, are the ones who are more responsible for little changes in position and for the proprioceptive facilitation, neuromuscular facilitation. So we can see that core stability is important in many sports. And so we heard about the anterior abdominal wall all day, so I will go through that. And just in the transversus abdominis, it has been mentioned that is its action is delayed with groin pain, and also the timing of onset of activity is also delayed in sufferers of chronic low back pain. And I can say that we can learn a lot by people who specialize in low back pain, because they apparently do much more studies on these muscles than people who are treating the groin. So we have the same muscles in the posterior abdominal wall, and you can see on this slide all the muscular structures that are working together to help maintain core stability. And in the posterior abdominal wall, you can see where are the origins of the abdominal muscles that we call the external oblique, the internal oblique, the transversus coming all the way from the back, also external oblique intersecting with the latissimus dorsi. More back muscles, and the most important, multifidus. It's been proved that action of multifidus and transversus abdominis is impaired in low back pain, and that localized exercise program for multifidus will increase the cross-sectional area of the muscle. So we took a look at the walls of the box. Now we had to take a look of the roof and the floor. And especially when you talk about pelvic floor, the famous surgeon in the US who is dealing with the groin is describing his surgery as anterior pelvic floor repair. And from what I heard in different congresses from people who are doing the same and learned from him, it's apparently inguinal region repair. So an inguinal region and anterior pelvic floor are different entities, just to add to the confusion. So there was a study from some people in Czech Republic using dynamic MRI and spirometry to assess the diaphragm function, and you can see that there are different diaphragm excursions or contractions during different tasks. So the solid outline is the normal tidal breathing. The dotted outline is the upper extremity isometric contraction, and the dashed outline is the lower extremity isometric contraction. So you can see the diaphragm works more with leg movement. And then there are some studies from Australia looking at the pelvic floor. It's published in Neurology and Neurodynamics, so we can take a piece from different fields of medicine. And so it shows that coordinated muscle action generates and controls intra-abdominal pressure. All the muscles surrounding abdominal pelvic cavity influence pelvic floor muscles, and all of that varies with different lumbar spine positions. So in this study, they also showed, and you can see here, that of course low muscle activity during rest, during pelvic floor muscle contraction, of course the pelvic floor muscles are the ones who are working the most, and you can see on the right that all the muscles are working with Valsalva, and the one that is working the least is the rectus abdominis. So basically, when we see someone with a nice six-pack, it's probably more for the beach than for core stability. So the weak links that are bothering us, and you can clearly see that I'm a follower of Professor Holmich in this presentation. We like to simplify our terminology, and we divided the problem into inguinal, adductor, and iliopsoas-related groin pain. And I would like to add that it's very important when you see a patient to take a careful history, follow the time frame, because patients like to tell you their story and maybe miss something that they think is not important. It's very important for us. And it's also very important to know your or their physiotherapists and to know what they are doing. Because if they just come to you and said, I had 2 months of physiotherapy, I'm not better, that doesn't mean that they really did the right stuff. So, of course, we had a standardized examination, and plus we have to pay attention to the hips movement, lower back, and pelvic stability, and especially gluteus medius, as Roald mentioned today. Then we have the conservative treatment, which is, I on purpose put these photos because they're not addressing adductors or inguinal region exactly. They're working on the whole body. And then after finishing that, you need to have a functional examination, which means the patient can be completely pain-free on examination, clinical examination, but that doesn't mean that he's ready to go back to play and to do sports. And then they have to do sport-specific rehabilitation. And after that, if they're strong enough, they can return to play. And some of them get surgery. So in our hospital between 2009 and 2012, we had 266 registered athletes with groin pain in OPD, and 42 out of them had surgical treatment, which brings us to nearly 16%, which is a little bit different from Gilmore's 60%. Surgical treatment, what we did in these previous 4 years, some of the patients got inguinal shoulder repair, which is, I will not go into too much into details, but you just need to know it's a 4-layered open inguinal repair with suture, not a mesh. Or some of them got adductor tenotomy. So this is the breakdown by years. In 2009, we had 15%, but we just started working, and probably people didn't know about us. Then we had more patients, more athletes in OPD, and more surgeries. But then probably we developed our skills more in examination and physiotherapy, so you can see that the numbers dropped down. Now, in 2012, we saw less patients. My explanation is that probably also the other doctors, club doctors, got more proficient in treating groin pain, and that we now see a selective group of patients that maybe need surgery. But even with these numbers, with, like I said, 16%, when you just go through the files, and this is not a real follow-up or a real study, it's just a brief overview of the results. We had 10 patients with some symptoms, like some adductor pain after inguinal surgery, or some adductor pain after adductor tenotomy, etc. So 10 patients out of 40 is 25%. So again, on the contrary of people who are reporting 95% of success. So this is the breakdown by surgeries, what we did. So the red ones are combined procedures, and where it says H, it is a real hernia that was operated. So the mean return to sport was 4 months, median 3 months. The difference because one patient had, it was a goalkeeper, had a nerve entrapment after surgery and had a long recovery, and so he came back to play after 17 months. Basically, the majority of the patients were 2 to 3 months, with some of them 5 to 6. So just to go back, now we have a task to call back all the 266 patients, if we can get them, and to do the Arabic translated, validated Hagos questionnaire, and then it will be a real follow-up after 4 or 5 years of surgery. And so just a little bit of entertainment, some of the real players that we knew throughout history waiting for the World Cup and winning the World Cup. And I would like to say that I mentioned Nesovic at the beginning, who did his first surgery in 1967. So this is Professor Peter Higgs, a physicist, who in 1964 proposed the model of subatomic structure, so-called Higgs boson. And during these 50 years, they managed to make the big laboratory in CERN near Geneva and the Hadron Collider, and to prove that there is a Higgs boson. So I think if they could do this, we have a lot of work to do ahead of us. Even though there will be different reactions to our discoveries, but we have to live with it, because in this case, scientists would be doctors, military would be people from the clubs, and the public will be the public. Thank you very much.